to understand and remember because there are a lot of causes. So recall that the anion gap is sodium minus chloride plus bicarb. The bicarb is going to be low in a metabolic acidosis by definition, so some other negative substance has to increase to balance. The other substance is not chloride in these disorders. If the other substance was chloride, we'd have a normal anion gap. In the anion gap metabolic acid-base problems, the other substance is an unmeasured anion. It's something with a negative charge that is not chloride and therefore is not counted in the anion gap equation. So this is the list of causes of anion gap metabolic acidoses, and everything on this list creates some unmeasured anion that raises the anion gap. So we'll talk about all of these in the next few slides. We'll talk about methanol and uremia and DKA and propylene glycol, iron tablets or INH, lactic acidosis, ethylene glycol, and then finally salicylates, which is aspirin. And most people remember these causes by the mnemonic mud piles, which is the first letter of each of the causes of an anion gap metabolic acidosis. So we'll start with methanol. Methanol gets metabolized to formic acid, and formic acid is really bad. It's a central nervous system poison. It can destroy your optic disc and make you go blind, and it can put you into a coma. Methanol is found in antifreeze, de-icing solutions, windshield wiper fluid, lots of solvents and cleaners and fuels, and lots of industrial products. So the classic scenario for methanol intoxication is someone with a suspected ingestion. It may be a child who did it by accident, it may be a suicide attempt, or it may be an alcoholic who couldn't find alcohol and so drank methanol instead. The patient will have confusion from the CNS toxicity. They might appear inebriated. And then very importantly and very high yield to remember, there will be visual symptoms from the formic acid affecting the optic disc. And then of course there'll be a high anion gap metabolic acidosis. The treatment for methanol intoxication is to inhibit alcohol dehydrogenase. So alcohol dehydrogenase bioactivates methanol, converts it to formic acid, and that's the toxic metabolite. So if you give ethanol, that will help. That will block alcohol dehydrogenase from doing its job on methanol. And then there's also an antidote called flumetazole or antazole that can sometimes be used. But both of these are going to inhibit alcohol dehydrogenase so the methanol does not get converted to formic acid. Next, we'll talk about ethylene glycol. So this gets metabolized to unmeasured anions glycolate and oxalate. And both of these are kidney toxins. They have very slow excretion. And just remember that ethylene glycol destroys the kidneys. Glycolate in particular is toxic to the renal tubules. And oxalate, you may know, can cause calcium oxalate crystals. That's what forms certain kinds of kidney stones. And just like methanol, ethylene glycol is found in antifreeze and solvents and cleaners and things like that. So the classic scenario here is going to be another suspected ingestion, the same situation, maybe a child, maybe a suicide attempt, maybe an alcoholic. But then instead of the visual symptoms, you will see flank pain, oliguria, and anorexia, and these are all from acute renal failure. And then of course there'll be a high anion gap metabolic acidosis. And this has the same treatment as methanol. You need to inhibit alcohol dehydrogenase so that you don't turn the glycol into its toxic metabolite. So once again, you can use ethanol intravenously or flumetazole, that antazole antidote to ethylene glycol intoxication. Just to make this point very clear, here's a slide from our biochemistry module on ethanol. At the top of the screen is the chemical structure of ethanol. Ethanol is what you consume when you drink alcoholic beverages. It's metabolized by alcohol dehydrogenase into acetaldehyde. Also on the screen are the chemical structures of methanol and ethylene glycol, and you can see that they have very similar chemical structures to ethanol, so it's easy to understand why methanol and ethylene glycol are also metabolized by alcohol dehydrogenase. Methanol is converted to formaldehyde, which can become formic acid, and ethylene glycol is converted to glycoaldehyde, which can become glycolate and oxalate. So if someone has taken a toxic overdose of either methanol or ethylene glycol, you can treat that by administering ethanol. Ethanol will compete with methanol and ethylene glycol for alcohol dehydrogenase, and when ethanol binds to the enzyme, that will prevent the binding of methanol and ethylene glycol, and it will decrease their conversion into the toxic products. Propylene glycol is another chemical that's sometimes used as antifreeze because it lowers the freezing point of water. It's also been used as a solvent for intravenous benzodiazepines, and in the past, patients who were on dosages of IV benzos that were too high developed propylene glycol toxicity. It gets metabolized to pyruvic acid, acetic acid, and lactic acid, and it has many adverse effects. It can cause hemolysis, it can cause seizure and coma, and multi-organ system failure. It gives you a high anion gap metabolic acidosis from the lactate. That's one of the unmeasured anions in this situation. And the main clinical feature of an overdose of propylene glycol is just the CNS depression. There are no special visual symptoms or nephrotoxicity here like there is with ethylene glycol and methanol. Next, let me mention isopropyl alcohol, which does not cause an anion gap metabolic acidosis. But the reason I'm mentioning it is because it's found in many of the same industrial products as methanol and ethylene glycol. It has effects very similar to ethanol, and a key scenario is an alcoholic who can't get his or her hands on some booze, so they ingest some isopropyl alcohol. It gets converted by alcohol dehydrogenase to acetone, and acetone is much less toxic than the metabolites of methanol or ethylene glycol. Importantly, it does not cause an anion gap metabolic acidosis, as I said, so if someone's ingested toxic products but they do not have a high anion gap acidosis, it suggests isopropyl alcohol, and this is something you'll learn about if you ever do a rotation in toxicology. There's no role for fomepizole or ethanol here, and the main symptom of ingestion is coma. So I just mentioned this because it often comes up in the same areas as methanol and ethylene glycol. So moving on with our mud piles list of causes of anion gap metabolic acidosis, the next one is uremia. So advanced kidney disease can cause an anion gap metabolic acidosis, and I underline the word advanced because it has to be advanced. Early kidney disease is different. That causes a non-gap acidosis. The reason for this is because the tubules aren't working in early kidney disease, so they don't excrete hydrogen ions like they're supposed to. This means that more bicarb goes out in the urine, and then the body retains chloride to balance the charge. This gives you a normal anion gap. In later, more advanced kidney disease, you cannot excrete organic acids, so you retain things like phosphates, sulfates, urate, and other anions, and this increases the anion gap. But it has to be advanced kidney disease, and it's usually associated with other uremic symptoms like pericarditis and confusion and hyperkalemia. Diabetic ketoacidosis classically causes a high anion gap metabolic acidosis. This usually occurs in type 1 diabetics. Their insulin requirements rise, but they cannot be met because their pancreas can't make enough insulin. A classic trigger for this is an infection or a diabetic who stops taking his insulin. As you know from biochemistry, fatty acid metabolism leads to the production of ketone bodies like beta-hydroxybutyrate and acetoacetate, and these are the unmeasured anions that are going to increase the anion gap and cause an acidosis. The high levels of glucose draw fluid into the tubules of the nephron and increase the urine output, so patients with DKA have polyuria. The polyuria makes them dehydrated, so they drink more and they have polydipsia. Basically, the glucose acts like an osmotic diuretic, creating a diuresis effect. DKA patients have abdominal pain and nausea and vomiting. The mechanism of these symptoms is not clear. And then DKA classically has something called Kussmaul respirations. These are deep, rapid breaths that patients take with DKA, and they're caused by the acidosis. The high levels of ketones cause an anion gap metabolic acidosis, and then the treatment for DKA is to administer insulin to lower the glucose, IV fluids to rehydrate the patient, and then very importantly, you have to give potassium because the patients can get dangerously hypokalemic when you begin to administer the insulin. Next cause on our mud piles list is lactic acidosis, and this occurs when you get low tissue oxygen delivery. Pyruvate gets converted to lactate, and when lactate levels get high, usually greater than 4 millimoles per liter, you get a lactic acidosis. And lactate is an unmeasured anion that gives you an anion gap metabolic acidosis. This occurs in a number of clinical scenarios that you should know. So any patient who has shock for any reason, whether it's septic shock or cardiogenic shock, has poor tissue perfusion and can develop a lactic acidosis. Patients with ischemic bowel classically get a lactic acidosis. One of the rare and dangerous side effects is metformin therapy. It can cause a lactic acidosis, especially in patients with renal failure. Patients who have seizures can get so much muscle contraction that they develop a lactic acidosis. And then finally, heavy, strenuous exercise can sometimes cause a lactic acidosis. Next item on our mud piles list of causes is iron. So this happens when you have iron poisoning. This usually is a child who ingests iron unintentionally. Initially, there's a GI phase where there's abdominal pain, and this is due to direct toxic effects of iron on the GI tract. But then about a day or so later, you'll start to see cardiovascular toxicity. So these patients can go into shock and become tachycardic and hypotensive. They also get a coagulopathy because iron inhibits thrombin formation and function. They get liver failure from hepatic dysfunction, and this also can worsen the coagulopathy, so these patients are highly prone to bleeding. They can also get acute lung injury from the direct toxic effects of iron. And in this phase is when you often see an anion gap metabolic acidosis. When patients recover from the iron overdose, weeks later they often get a bowel obstruction. This is because you get scarring at the gastric outlet where the iron accumulates. So there's two reasons you get an anion gap metabolic acidosis during that acute phase. First of all, there are ferric ions, which are unmeasured anions. And then also these patients often hypoperfuse their tissues, so then they can get a lactic acidosis. So both of these things can contribute to a high anion gap metabolic acidosis. Next item on our list is isoniazid or INH. This is a tuberculosis antibiotic, and an acute overdose can cause severe seizures. In fact, it can cause status epilepticus. And all this seizure activity can lead to anaerobic metabolism, and that can cause lactic acidosis from muscles. So the lactic acidosis is what gives you an anion gap metabolic acidosis. And then the last item on our mud piles list is salicylates, and this means aspirin overdose. So it's very high yield for your boards to know the metabolic consequences of an aspirin overdose. So aspirin causes two acid-base disorders. Shortly after ingestion of an overdose amount of aspirin, you get a respiratory alkalosis. This is because the salicylates stimulate the medulla, and recall that the respiratory control center is in the medulla, and this leads to hyperventilation, and the patient will blow off CO2 and get a respiratory alkalosis. Several hours after aspirin ingestion, an anion gap metabolic acidosis will develop. This is because the salicylates decrease lipolysis and they uncouple oxidative phosphorylation, and as you know from biochemistry, this inhibits the whole citric acid cycle. As a result, you get accumulation of pyruvate and lactate and keto acids, and all these can lead to an acidosis. So because it causes two disorders, the pH is variable. It may be acidotic, or it may be alkalotic, or it may even be normal. It depends on when you catch it. The CO2 level is usually low due to hyperventilation, and the bicarb level is also usually low due to acidosis. Importantly, if it's an acidotic patient and you use Winter's formula to determine the predicted CO2, you will find that Winter's formula predicts a CO2 higher than what you actually have. Or to put it another way, the CO2 for the patient will be lower than what you expect for the compensation, and that's because it's a mixed disorder. This is easier to understand if we go through a sample case. So let's presume we have a patient with a pH of 7.3, a PCO2 of 20, and a bicarb of 14. The pH is low, so it's an acidosis, and the bicarb is also low, so this means it is a metabolic acidosis. Now the PCO2 is low because the lungs are compensating, but we're going to use Winter's formula to determine if that compensation is appropriate. So Winter's formula says that the expected PCO2 is 1.5 times the bicarb of 14 plus 8 plus or minus 2, and this works out to 29 plus or minus 2. So our actual PCO2 is 20, and that is lower than expected, and that is because aspirin is leading to hyperventilation and causing a concomitant respiratory alkalosis. And this is what you can see in an acid-base problem of a patient with aspirin overdose. And that concludes our module on metabolic acidosis.